like to thank Mikhail and the program committee for the opportunity to speak with you today. It's very wonderful to be in Graz. So, and now for the crazy talk, as I was already introduced. I do need to disclose I'm a co-author of a patent. I've got no financial interest in any of this, and we have grant support from the Department of Defense in the United States, and I'll be talking about off-label use of saline and cardiopulmonary bypass equipment. So this is an example of a case, and this was a specific case that I was involved with that got me interested in this whole topic of cardiac arrest and trauma. And as a junior surgical resident, I spent a couple months along with my wife, who's an ER physician, at the Shock Trauma Center in Maryland. And we had a young male who had a stab wound to the heart. He arrested in the trauma resuscitation unit, which is essentially the emergency department for the Shock Trauma Center. And despite being at one of the biggest trauma centers in the world and doing everything right, we couldn't save him. This actually is a picture of what the TRU looked like back then, and the stabbing had something to do with some kind of argument about bowling shoes, but it's very sad. But despite doing all things right, we still can't save a lot of these patients. And it just so happened that a couple months after that, I started working in a lab with hopefully someone that's recognizable to most of you, Peter Saffer, who is known as the father of CPR from Vienna originally before he moved to the US and to Pittsburgh. And I started working with him as a medical student when I saw a little ad on the board that said looking for medical students to do cardiac arrest research. I thought, that sounded kind of cool. And we'll get to how cool it was, but we'll get there. So with that as background, what I plan to do is kind of talk about a little bit of CPR, a little bit about post-arrest hypothermia, cardiac arrest and trauma, hypothermia and trauma, and then kind of put all this together in what we call EPR, or emergency preservation and resuscitation. So starting with CPR, as I mentioned, Peter Saffer was recognized as the father of CPR, and when he first talked about the ABCs, he actually went on to D, E, F, G, and H. This is about 1960. He was already including the concept of hypothermia if you have a patient that's been resuscitated from a cardiac arrest and isn't waking up. So that idea has been around now for 60 years or more. But what about the actual use of this, the science behind it? I won't go into much detail other than to comment on a couple of things that probably most of you are aware of, that this idea of post-arrest hypothermia was tested in a couple clinical trials. This first one, the hypothermia to cardiac arrest trial that was done here in Europe and run in part by Fritz Sturz, who was actually a fellow with Peter Saffer when I was a fellow with Peter. And then also Stephen Bernard's study from Australia, both randomized trials showing that hypothermia, cooling the patients down to 33, 34 degrees after resuscitation from cardiac arrest, seemed to have some benefit. Now, of course, like a lot of things in the literature, as already commented, you need to kind of look in the details and question what's behind the studies. And one of the things that came up when people started doing more of that was that the normothermic group in those studies actually sometimes had fevers, which we know is bad for the brain after a cardiac arrest. And so the TTM, or targeted temperature management study, was done where they controlled temperature more specifically in the normothermic group. So it's 33 versus 36, and they found no difference in outcomes. This was essentially kind of repeated with the TTM2 trial, where the hypothermia was basically the same, but the normothermia was a little looser. The patients could get up to 37.5, but again, no difference. So probably the takeaway is preventing fever if you've been resuscitated from a cardiac arrest is the most important thing, and may not be that helpful to get down to something like 33 or 34 degrees. But the questions are still out there as to when to use hypothermia, how cold, how long. All those questions are still to be answered. But we still have at least some recommendations that haven't changed significantly, but who knows, the new guidelines might come out next month and change this. But if you do have a patient who is comatose after cardiac arrest, targeted temperature management, essentially picking some type of temperature between 32 and 36, is still pretty standard, at least in most of our centers, although a lot of people now would say 36 is fine, but you should at least actively prevent fever. Now, what about trauma patients? Let's touch on trauma patients for a second here, because back when, before the TTM trial and after the two randomized trials came out, there was a small study of patients at Shock Trauma Center where I'm working now, where they actually had trauma patients who were comatose after cardiac arrest from trauma, and they cooled them to 32, 34 degrees for 24 hours. They're extremely badly injured. They didn't necessarily do very well, but at least there was no clear evidence of complications from hypothermia. And in terms of that, I'll just make a side comment without getting into lots of data, because there isn't that much, but the effect of hypothermia by itself on coagulation is really pretty minimal until you get down certainly below 33 degrees and probably not to 30 degrees. But it's just a very difficult thing to study because all the machines we use for coagulation tests warm the blood up to 37, so it's very hard to study hypothermia and coagulation. But they didn't think there were any complications related to hypothermia itself. Now, turning more fully to discussing cardiac arrest and trauma, the basic principle, the basic problem is CPR just doesn't work. I mean, CPR works fine if you have blood in your system and you can push on the chest and you can get blood flow. Most of the time when people have arrested from trauma, they've done so because they've exsanguinated. There's no blood in the system. So pushing on the chest just physiologically doesn't do very much. And not surprisingly, even if we do all the right things, we intubate people, we put in big lines, we give them blood, even if we give them whole blood probably, and we open the chest, which is what we as trauma surgeons will do to try to find an injury we can fix and to do direct cardiac massage, and also clamp the descending aorta, the outcomes are terrible. This is a study from over 20 years ago at Peter Ree, where he reviewed all the literature up until then. Overall survival, if you got an ED thoracotomy, which meant at least somebody thought there was some potential of saving you, your potential for surviving was about 7%. And I've looked at our data at the Shock Trauma Center, and now 20 years later, it's the same. Nothing has changed. Now, how can we try and figure out how to make some change here? So, this is a graph showing the time to death of soldiers that were killed in battle in the Vietnam War. And again, Peter Saffer, along with Colonel Ron Bellamy from the U.S. Army, who gathered this data, looked at this and saw, well, there's something interesting here. First off, there's some of them that died immediately. And they probably have injuries that no matter what, we just can't fix. We can't save them. But there are a number of them who die within 5 minutes, 30 minutes, an hour, 2 hours. That's a time frame where if you had something novel you could do that could impact their outcome, maybe buy some time to get them to a surgeon or some higher level of care, you might be able to save them. The other thing is they did autopsies on all of them. And a lot of times they had fixable injuries. So here you have people that are injured, they're dying, but if you could get them to point A to point B or get the surgeon to them, whichever you can do, and you could buy some time with some sort of therapy, they could be salvageable. So one question is, could hypothermia be the answer? We'll come back to that. But some reasons that it might be are some things that I've already mentioned. So first off, when we were talking about this and looking at this in the lab, which was back in the early 90s, we were already looking at hypothermia after cardiac arrest, after non-traumatic cardiac arrest, a little bit of cooling. There were many reports of people who drowned in cold water and were underwater for upwards of an hour or more, and they could still be resuscitated and survive. So the cooling, very quick cooling, could protect your brain during cardiac arrest. And our cardiac surgeons have known this for years. They've been using circulatory arrest to allow them to stop all the circulation in the body, to be able to operate on little babies with congenital heart defects or adults with aortic disease. So based on all of this, perhaps hypothermia could buy us the time we need in these trauma patients. So we've come up with this concept that we call EPR, emergency preservation and resuscitation, protection, preservation of the organism during circulatory arrest of 2 hours or more for transportation, control of bleeding, and then delayed resuscitation, with the idea that this could allow survival from otherwise lethal injuries. And the basic principle here is that all we're trying to do with the hypothermia is buy time. And you'll notice too that EPR does not have the word hypothermia in there, because we do have a hope that we can come up with some chemical cocktail or some other way to do this, because hypothermia is very difficult, as I'll show you. But what do we already know about hypothermia and trauma? And I have to be honest about what our current thinking is about hypothermia and trauma. So hypothermia could be good in that it decreases oxygen consumption, decreases free radical production, inflammation, excitatory neurotransmitters. But on the bad side, it can increase coagulopathy if you get cold enough. There's stress, there's shivering. So there's definitely a downside to hypothermia. And it was actually already mentioned, we have this triad of death of acidosis, coagulopathy, and hypothermia. And certainly in the trauma world, the standard of care is and should be, for now at least, keep people warm or get them warm as fast as possible. But if you look at the data, one of the big questions that comes up is if you look at increasing injury severity, the more injured patients are colder and they have a higher mortality, but is the hypothermia itself really helping to cause the mortality, or is it just sort of an epiphenomenon that as you die, you get colder, and it's not the cold that's killing you? And there's clearly a difference between exposure hypothermia, which is what happens with our trauma patients, and therapeutic or targeted or controlled hypothermia, which is what we do to utilize the potential benefits of hypothermia. And I'm not going to show you a lot of data, but I'll show you a few animal studies just to point out a couple things. First, I'll say that in at least animal models of hemorrhagic shock and cardiac arrest, it is really easy and very consistent to show that a little bit of cooling is beneficial. This is just one study that we did with 3 hours of shock, hypotensive or limited fluid resuscitation. We added a splenic injury and looked at normothermia versus hypothermia with giving some ice cold fluid to try and cool them faster, or hypothermia with just room temperature fluid and exposure hypothermia, or surface cooling, I should say. And we found that basically in normothermia, most of the animals died very quickly. They didn't even survive the shock state. The cooling with ice cold fluid seemed like a good idea at the time, but it really didn't work out too well, because a couple of the animals, as soon as the cold fluid hit them, they immediately suffered a cardiac arrest. So that didn't work out well. But just using surface cooling, a little bit of room temperature fluid to cool them down, they almost all survived. And again, this is very reproducible. But why is this dichotomy true? That in the animal model, it's really easy to show that hypothermia is good if you're in shock, but in our humans, it seems pretty bad. Well, is it stress? Certainly our patients are stressed. The animals are not. They're under anesthesia. Is it shivering? Our patients shiver. The animals don't, again, because they're under anesthesia. Is it blood products? Our patients may get more whole blood now, but they certainly haven't much in the past, so they get some sort of balanced or an unbalanced blood resuscitation. And it's all blood bank blood. It's not their own blood, whereas the animal models, they almost always get their own blood, and it's whole blood, and it's warm, and it's fresh. I don't know. Nobody knows the answer to that. But it's an important question that's out there. So hopefully now I've laid a little bit of groundwork of what we know about cardiac arrest in general, cardiac arrest and trauma, and hypothermia related to trauma and cardiac arrest. So let's move to EPR. So when we first thought about doing this cooling, so that, again, the idea is to cool very fast to get this, particularly the brain and the heart as cold as possible quickly in an animal that is in arrest or arresting from exsanguinating hemorrhage, which is the main cause of arrest from trauma. We first thought that it would be useful to put a balloon up into the aorta, a balloon tip catheter, so that the fluid we give for this cooling, and we thought that core cooling with cold fluid was the best way to do this. Surface cooling would be just much too slow. And for those of you who might recognize a balloon up in the aorta, this is very similar to ROBOA, or resuscitative endovascular balloon occlusion of the aorta, which also could help stop bleeding distal to your balloon. But this is something we were looking at before ROBOA became a thing. The problem with this is, as you looked at longer periods of no blood flow, it seemed like having the balloon up in the aorta was allowing ischemia of the spinal cord and perhaps the gut. So both the models that we used, we basically tried to flush the whole animal with cold fluid. And I'll just show you this one study. This is sort of our general model of, we would exsanguinate the animals, bleed them down. We'd induce VFib, so we knew exactly when there was no blood flow. Wait a few minutes of no flow, and then flush them with this cold, we just use cold saline, nothing fancy, not blood products, just to cool the core of the body as fast as possible. And the temperature goal was dependent upon the individual study, and we would have either anywhere from 15 minutes up to 180 minutes, so 3 hours of no blood flow, which basically meant we could cool the animals, they're in arrest, we can go off, have lunch, come back, and resuscitate the animals. Now, if they're that cold, because we would cool them down to, in some of the studies, down to 10 to 15 degrees centigrade, tympanic membrane temperature, because we were focused mostly on the brain, the only way to resuscitate them would be using heart-lung machines. We had a closed-chest cardiopulmonary bypass model. And then we would apply post-arrest mild cooling also. And it was pretty easy to work out a dose-response curve where if you want 15 to 20 minutes of no blood flow, 34 degrees is fine. But to get to 90 minutes or more, you need to cool the brain to membrane temperature down to 10 degrees. 90 minutes, this is the overall performance categories where 1 is good, 5 is bad. And 90 minutes, they all survive, seem normal. 2 hours, again, 2 hours no blood flow at 10 degrees, they survived, but many of them had some neurologic disability. And we found that to cool the whole body of a large animal to these kind of temperatures required a lot of fluid. So we try to look at what could we add to that fluid to improve the outcome without having to use so much cold fluid. Well, this is a diagram of what happens in neurons during ischemia and reperfusion. This was, I believe, drawn after Peter Saffer and Pat Kohanek, who's now the director of the Saffer Center, had a couple bottles of good Austrian wine, and they came up with this drawing. It's actually scientifically valid, just interesting drawing. But based on the science at the time, we came up with a list of drugs that might be beneficial to the brain and could allow us to not have to use so much cooling. We tried this in a bunch of small experiments, no benefit of any of them except Tempol, which is a powerful antioxidant. So really the cooling so far, at least in terms of the science, is the only way to allow 2 hours or even longer periods of no blood flow. Now we also have to consider trauma and injury and surgery, because most of the studies we did, we didn't really have any significant trauma, we just cooled the animals down. So this is the one last study I'll show you from us. Prolonged shock, 2 hours of shock, this is something the military really wanted to see. After 2 hours of shock, the animals would arrest, and we randomized them to doing CPR and giving them their own blood back, or cooling them down, leaving them for another hour of no blood flow, which would be the time clinically of moving them from one point to another where the trauma surgeon is, and then resuscitating them, again, resuscitating them with bypass. And just to make it clinically relevant, we actually opened the abdomen, transected the spleen, and then during this period of resuscitation, we actually took the spleen out, so it was very clinically relevant. And what we found was that in the CPR group, none of them survived. In the EPR group, if we just kept them a little cool for another 12 hours, they mostly survived but had significant neurologic disability. If we kept the hypothermia, mild hypothermia, post-arrest for a longer period of time, 36 hours, that seemed to do better, which comes back to my point earlier that with this whole TTM after cardiac arrest, we don't know what the optimal timing is, duration, temperature, and this is just one example of where more prolonged post-arrest cooling is good. Well, we aren't the only ones who've looked at this. Lynn Yoffe's in the middle there, was the director of the Naval Medical Research Institute. Peter E., Hassan Alam, did some work with him and on this whole concept also, and they made a couple of really important findings that the faster you cool the animals, the better the outcome, which kind of makes sense because they're already in arrest, so you got to get the protection of hypothermia on board quickly. Rewarming can be kind of medium, middle of the road, that's okay. But they also showed if you add a bunch of injuries that you can still have good outcomes. So based on our work and their work, we all felt like it's time to do this, take this to a clinical trial. So we're currently conducting what we call the Emergency Preservation and Resuscitation for Cardiac Arrest from Trauma study at the Shock Trauma Center at the University of Maryland. So how is this study working? Right now we're looking just at people with penetrating trauma, gunshot wounds, stab wounds, and sadly in Baltimore we have plenty of this. 18 to 65 years of age, no silver trauma patients here. They had to have had signs of life. in the field, and that's within 5 minutes of the ED or trauma resuscitation unit arrival. So we don't want the person who's been arrested for 20 minutes as part of this trial. We're trying to find that fine line between doing it in people who are going to do well no matter what we do and people that are going to do poorly no matter what we do. So we're trying to find that middle ground. So we want people who arrest, lose a pulse within 5 minutes of getting to the hospital, and then remain pulses with our standard therapy of intubating them, giving them blood, opening the chest, clamping the aorta. We exclude, this is the usual exclusion from any trauma studies. If they've been in arrest longer periods of time, obviously non-survivable injuries, massive trauma, pregnancy, prisoners. So how does this actually work? So the patient has a cardiac arrest. They come to us. We do the ED thoracotomy. If we get a pulse back, great. Then they don't need EPR. If we don't get a pulse back, and we're talking about within just a minute or two, decisions have to be made very quickly. So the next question is, does the patient meet our EPR criteria, which I just showed you? If the answer is no, then in most cases, then that would be the end of the resuscitation. If they do meet our criteria, and this is a really important piece of this, the next question is, do we have all the people necessary to make this work? And I'll tell you more about that in a minute. If not, we actually will follow those patients as part of a concurrent control group. If they do meet our criteria and we have the right people, we cannulate the aorta. The chest is already open. We start this cold saline flush. We open the right atrial appendage to drain the venous side. We release the aortic clamps, and now the whole body is getting cold after we've already started to cool the brain and the heart. And then once we get the tympanic temperature down around 10 to 15 degrees, we stop the flush, rush the patient to the operating room. And in the operating room, the trauma surgeon does what the trauma surgeon needs to do. Cardiac surgeon puts the patient on full bypass. And our goal is to get 10 people who get EPR and 10 in our control group. The outcomes are kind of typical trauma outcomes: survival, discharge without major neurologic sequelae, direct complications of the technique, coagulopathy, organ failure, longer-term survival, and neurologic function. And as you can imagine, we have a large team that we need for this: the trauma resuscitation unit staff, trauma anesthesiologists, perfusionists, cardiac surgeons, OR staff, cardiac anesthesiologists, blood banks. So there's a lot of training that's needed to this kind of study. We've done training with animal models to really get the team up to snuff as to how to do this. This is a picture after our first trauma training, but we've also used simulation.
24-year-old male, 2 gunshot wounds to the chest, 1, 2, 3 lift, and down.
Resisting ventilations, gunshot to the right chest, gunshot.
This patient's been shot. He's lost so much blood, his heart has stopped.
I don't have a cardiac pulse.
No femoral pulse.
I have no pulse. Medic, can you come and do CPR, please?
The ER team are trying everything to get his heart working, but they're getting no response.
Dimitri, I'm getting no cardiac activity. Let's initiate EPR. 32, okay.
What they do next is extraordinary.
Need ED cooling? We start bringing the temperature down. Pump's ready to go.
They slowly pump the remaining blood from his body and replace it with ice-cold saline solution. This induces a state of severe hypothermia.
So as you can imagine, trying to do something that's this complicated and very uncommon to do, you need to keep everybody up to speed as to how to do it. So running simulations, running dry runs, having everybody walk through how to do this is really important so that we're ready when the right patients come in. And what I'm talking about now is doing this in the hospital at a major trauma center, but we do have hopes that if we can show this can work, that in the future we can take this outside the hospital. That's why our military is interested in it. It might be civilian medics also, that if we come up with portable cooling devices, cold fluid, maybe chemical ways to decrease metabolism, and we can then hopefully take this out into the field and save more lives. So to kind of summarize, for non-traumatic cardiac arrest, certainly our standard of care right now is targeted temperature management. With profound hemorrhagic shock, we have this sort of dichotomy of spontaneous mild hypothermia seems to be bad in our patients, but as I mentioned, therapeutically doing this in the animal models seems to be good. Nobody has tested this in a clinical trial. And then for exsanguination cardiac arrest, that's where we think EPR could have a role. We're still doing this study, and hopefully stay tuned, and when we have the study completed, we'll be able to talk about the results. But as I mentioned earlier, we have not really changed the outcomes in over 20 years, 30 years. So there's certainly plenty of room for improvement. Hopefully EPR will be the answer. So thank you very much for giving me the opportunity to talk to you this morning.